I spent some time over the years since 2003 with the US CDC, working primarily on radiation, but also working a little bit on in global health issues with the Center for Global Health. And our previous director, Dr. Tom Frieden, said something very important to us in one of his regular addresses. He said to us, CDC employees, pick a problem that is big. Pick a problem that is big and that you can do something about. These are the problems that you should tackle first in public health. And I think lead is an amazing example of a big problem that we can do something about and make a lot of good after we complete the project. So thinking about all of these inspirations in my career and adding to it a case report of a Georgian family that moved to the state of Massachusetts and was poisoned with lead because of Georgian spices they had brought with them, inspired me to ask the question in Georgia. This study is it's a case report from 2005. So the best partners to start this project with were certainly the NCDC, with support from the US CDC at the time and Ishvili Clinic. We conducted the first study or survey screening children for lead exposure. Certainly this study was a learning experience for all of us, and it was not something that could be generalized because the sample was a convenience sample of children attending Ishvili Clinic for well visit checkups. That study, we had about 230 children that were tested. And we had results that led us to today embarking on a study with UNICEF. We used for that study the point of care machine, which is called LeadCare. And the results we had helped us think a little bit about the problem, suspecting maybe an issue with paint, potentially, when we identified a child who was 5 years old with severe developmental delay, whose lead level was elevated. We investigated that home. Together as a team, we found out the paint was the source of that child's home. Since that time, this child has moved out of that dwelling, but we tested the water, we tested the soil, and the only thing that was abnormal was the paint, which was clearly deteriorating in that old dwelling in Tbilisi. Unfortunately, after we published our first evidence convenience sample study, there were some problems with the LeadCare machine. The accuracy of the results was questioned to the point where the United States Food and Drug Administration recommended no longer using that machine to test venous sample like we did. Casting a shadow on our results, we felt motivated to repeat the study. And we were able to repeat the study with NCDC in the Ishvili Clinic and with the support of the US CDC in 100 children. Those results were in the initial states of analysis. I'm not sure we can we should maybe talk about them today. I prefer to wait for our partners to get all the full results. But they show results that are overlapping with what we showed in the first study. The problem in Georgia from these two convenience-based samples is not a grave problem. But I think, as we will talk today in the next hour, any lead is a problem. You don't have to have a big problem to have a problem. Any lead in your environment, in your children and your adults is a problem, and we should all work together to control, as Dr. Kazzi said, this problem and best manage it. And this is only the first step today. What NCDC is doing today as leader with UNICEF and the Italian Institute is amazing. I'm very happy today to see this. I consider myself Georgian. I do. My kids are Georgian. They spend time in Georgia. I spend time in Georgia. And I know my kids and family are healthy and safe. My nephew, my niece, they live here. And having the support of UNICEF, having the support of the Italian Institute, Italian National Institute of Health, as well as the US CDC, is essential for us Georgians. It's essential for us, for NCDC and us physicians, pediatricians, emergency physicians, in understanding this problem. But this is only the beginning. We need to also work with the Ministry of Environment. We need to work with the Ministry of Agriculture and other partners as we navigate through this journey. So with that, I will start by talking a little bit about lead. So now we are going to start talking about some of the scientific medical content that we need to better control this problem. Most of you hopefully have completed a pre-test that I obtained from the CDC. This test we will complete again at the end of the day, and then you will see how much you have learned today from this program. Lead, first of all, is a metal, and it's very popular in industry because it's malleable and has a relatively low melting point, so you can melt it relatively easily. And this is not something new. Lead was recognized in Phoenician times, where they started creating the first lead mines. The Romans, Alessandro, your ancestors, used lead quite a bit. And many people talk about lead epidemics in the Roman Empire. So this is not a new problem, as everyone said here today. The main focus for us today is inorganic lead. Inorganic lead. We are not going to talk about organic lead because Dr. Kamkhalidze told us in 2000, Georgia banned the import of leaded gasoline. Leaded gasoline in the form of tetraethyl lead and tetramethyl lead was used to boost the octane content of gasoline. It is good for the cars, but bad for the people. Now this problem is no longer present in Georgia. However, we expect that the contamination from the use of leaded gasoline will last several years afterwards. Like we saw in the US. Even if you stop importing the leaded gasoline, you may still have some consequences for several years after that. Unfortunately, and this is something, of course, UNICEF is striving to eliminate, we do have leaded gasoline in other parts of the world. As far as I could tell from looking at public sources, it is still used in countries like Yemen, in countries like Algeria. I've seen Iraq, I've heard Myanmar, North Korea. Maybe Basil can comment on that later on when we discuss this problem. But at least this is something we don't have to worry about here in Georgia, hopefully. The paint, on the other hand, Dr. Kamkhalidze said that it's not regulated yet. Is that true, Dr. Kamkhalidze? So paint, lead in paint is good for paint, but again, it's bad for the people. Adding the lead to the paint makes it more durable and more malleable, and also gives you colors, because lead compounds have nice colors. They can be yellow if it's lead chromate. They can be red with lead oxide. And even lead acetate, which was used as a pesticide in the US for many years, is sweet. It can be sweet. So if you taste it, the child potentially will think it's a sweet food. The problem that UNICEF faces now around the world also is related to occupational exposures, contaminating the people that are working with the material as well as the environment. So the big problem is with the recycling of batteries. The batteries that you use in the car, people recycle this. They collect them and they recycle them. And people that work with that, they burn the battery to get the lead out. They can get exposed and they can contaminate the environment where they are doing that, and the air that they are burning these batteries in. Recently in the United States, as Dr. Kamkhalidze said, this is also a problem in the US. We had a problem with lead in Michigan, in Flint, Michigan. That was due to the water being contaminated because of the pipes. Our pipes that would bring water to the house are old. And if the water is acidic, has a high acid content, it can leach the lead out of the water, out of the pipes. Especially if the pipes are old, or even new pipes that have lead soldered to weld them together. That can also leach. Lead is used quite a bit in hospitals because of its way it shields radiation. So we use it to shield radiation. And again, like I said, it's used for batteries. So it has uses, but it also has its hazards when you are not disposing of it properly or when you are not working with it properly. I prepared this table in our first seminar on lead. Our first seminar on lead was here in the same room about 5 years ago. And I kept this slide because I think it's a nice summary of the issues we have to think about together in Georgia. And we have to find out which of these is important for Georgia. Environmentally, dust. Do we see a lot of dust that is contaminated with lead? Or is it paint? Is it paint that will be the biggest problem in Georgia? We have to find out. So far, that highest case we saw, it was paint as far as we could tell. Soil, is the soil contaminated? Of course, it could be contaminated. It depends where is that soil located and close to what? What factory, what highway, what road, where is it located? The water, is the water becoming contaminated because of the lead pipes? What is the acidity of the water that we drink in Georgia? Can it leach lead out of the pipes? What is the concentration of lead in air? And are we contaminating our foods, like spices, with lead? Could this be happening when you grind the spice with the equipment that may have lead in it? That's the question that comes to my mind, especially with the case that Dr. Khalid talked about in New York. In New York City, there was someone exposed to spice imported from Georgia, and that ended up on Facebook and ended up causing quite a bit of concern. Believe me, I know how important spice is. I know my mother-in-law, how she loves the spice in the food, and having a problem with spice is an important problem for Georgia. Occupational exposures. What occupations do we see here in Georgia? Let's think about it. Do we have people that repair radiators for the cars? Do we have people that work with batteries or recycle batteries? Do we have that problem? I don't know. We need to find out together. Do we have smelting operations where you melt different metals and recycle them? Do we have crystal glass makers? In the US, we have quite a bit of people that like to shoot their guns. I had a patient in my clinic that would go and shoot his gun in a special area every day on his lunch break. He would go and shoot his gun. On the weekend, he would have twice as much time because he's off. This person's lead level was always in the 40 microgram per deciliter, which is high. He even installed his own air filter at the club he goes to. He came to me not because he was concerned about his lead level. He came to me because his lead level increased from 40 to 60. He wanted to know, why did his level go up? We found out because he was buying cheap bullets. Because he was shooting so many bullets, he needed too much money, so he bought cheap bullets, and now these bullets were releasing more lead when he fired them, and he was inhaling it. So that's a problem. Do we have that in Georgia? Welders, painters, gold mining. I'm sure Basil can talk to the largest epidemic in modern times of lead poisoning in Nigeria. When gold prices increased about 10 years ago, there was increase in mining for gold ores in Africa, specifically in Nigeria. People brought the raw material from the mine to their house, and they broke it down with a hammer in their house. They asked their children to do that, and about 400 plus children died from this lead poisoning epidemic in Nigeria. We will talk a little bit about this later on. Again, we have to learn more about Georgia. What is the occupational profile in Georgia? What are the occupations that are high risk in Georgia? I mentioned this already. Battery cycling is a problem around the world. Here you see a battery collection site in Dakar, Senegal, where 18 children died of lead poisoning in 2008. Look at this map of the world identified by one of the non-profit organizations looking at sites of lead pollution from used lead acid battery recycling. Find out in your community if these exist. You are in the community, you are the community. You should be able to ask these questions to your neighbors, to your patients, to their parents. And if we don't do that all together, whatever we do together as NCDC or UNICEF or CDC or whoever you say, will not be able to be successful without your help. Because you are going to be the fighter, the soldier that's going to fight this battle in your clinic. And when you think about your children that you're seeing in the clinic, you need to consider all of these potential sources that these children are exposed to. I know we said that we think it's going to be in paint, but what about the soil, the toys? Toys imported sometimes from other countries that have less standard industrial standards may have lead in those toys, and children put the toys in their mouth and they'll get contaminated that way. Lead in water from the pipes, the auto emissions, which don't think is a problem in Georgia, other industrial emissions from neighboring factories or battery smelting plants, etc., can cause your child to be exposed to lead. Now, we also see secondhand smoke exposures. Children exposed to secondhand smoke, even third-hand smoke, but certainly has been shown in secondhand smoke, can increase their lead levels a little bit. And I know that smoking is a problem worldwide. And some parents smoke in the house with the children around. Unfortunately, still a problem in the world, even in the United States. So that's another source of exposure. I work quite a bit in the Middle East. Through the Middle East North Africa Toxicology Association, we become exposed to cases of lead poisoning from traditional remedies. People use lead in traditional remedies. My first case of lead poisoning that I took care of in my clinic was in 2003. It was an Indian person who lived in the United States with diabetes. And he would have first abdominal colics, abdominal pain, requiring CAT scans, ultrasounds, gastroenterologists. They thought he had porphyria. Then he came to my clinic and we found that he had a high lead level of 50 microgram per deciliter. This person had his lead level elevated because he used Indian traditional medications called Ayurvedic medications that he bought for diabetes from India that contain lead. So keep an eye out for lead poisoning from traditional remedies, herbs, type of products that people use. In Oman, in Sultanate of Oman, where I also work quite a bit with the Ministry of Health there, they use kuhl to darken the eye surrounding. That also is lead sulfide, can lead to lead exposures. So please, use these slides. You don't have to take notes, you can take those slides, but when you see a patient, a child, ask all these questions, because you are the only one that can make a difference in Georgia for your patients. Now that we've talked about the sources of lead exposure, how does the lead enter our body? There are only a few ways possible. In children, the most important way is through their mouth, through their gastrointestinal tract. In adults, it's more through breathing. But both breathing and oral can be a problem for both adults and children. When a child or an adult ingests lead, luckily for us, the absorption is not 100%. Children absorb more than adults. It's not 100%. However, the percent increases if the child or adult are fasting, it's an empty stomach, or if the child has an iron deficiency anemia, or a calcium deficiency, or a zinc deficiency. All of this can increase the percent that's absorbed. Absorption to the lung is higher. It will depend here on how much You are breathing, so children breathe more faster than adults, so they can have more absorption. Also depends on how much you have in the air. So if you're in a concentrated area, it may depend on the particle size. The smaller particles can enter the alveoli and become absorbable. And it also depends on the stature. A child is short and therefore is able to breathe more what's being becoming respirable through the dust. Just being shorter can give you a higher risk. And don't forget about the placenta. Your fetuses, through placental transmission, can take in lead from the mother. So the problems start during pregnancy, and we will talk about that today. We need to think about that. The child that I told you about in Tbilisi, they had a level that was elevated. His mom had had 5 miscarriages before. I wonder if lead was a problem. Her lead level was 32 microgram per deciliter, the mother. Skin, fortunately, is not a problem. Absorption is very low with skin. This is for inorganic lead. Organic lead, different story. That one is absorbed to the skin, but we're not talking about lead, organic lead today. We're only talking about the inorganic form. But since we're focusing on children today, remember that children's major source of exposure is leaded dust. And I think we're going to find, if we find whatever we find as a cause, may be related to dust and paint chips in Georgia. We will see. Once the lead enters the body, whether it's coming through the stomach or through the lungs, this is an important slide. It's a little bit complicated. I'll make it simple for you. It goes to the blood. This is important to know. About 90+% is in the blood, but not forever. The half-life in blood is 28 days. This is important when we do our test for these 1,500 children, we are testing their blood. So we are catching the lead in the blood. If the exposure is not continuous, we may miss the high level there because it will leave the blood and go to the soft tissues and go to the bones. In cases of continuous exposure, certainly the blood will catch it for sure. But this is something important to remember when you interpret the lab result in your clinic. Is this a continuous exposure or a one-time exposure? Because you can have a one-time exposure. A child can swallow a lead foreign body one time. Okay? So that's important. The second thing that's important is the soft tissue, the liver, the kidney, the brain. That compartment is still labile, so lead can go back and forth, but not as much as blood. So it's starting to being fixated and less mobile. When it goes to the bone, it becomes even less mobile, and most of the lead in our body is in the bone and will stay with us all our life, with little of it leaving, except in periods of stress where you break a leg or you have osteoporosis or you're pregnant or you're lactating, you're doing breastfeeding, then you can mobilize some of it from the bone. But a lot of the lead is in our bone, and that's a whole different story to measure lead in bone, which can be done using X-ray, but is not necessarily well utilized scientifically and medically. We don't know very well what to do with these results, but those can be done as well. You can measure lead in bone and will give you a true estimate of your lifetime exposure or your lifetime body burden of lead. We do excrete some in urine, a small amount, and I want to show you one thing that's important here. Your bone has about 200 milligrams of lead in exposed people. Those are exposed. Severely exposed adults who've been working with lead all their life, they may get 400 milligrams of lead in their bone. Look how much you have in the blood, about 2 milligrams. 2 milligrams, 200 milligrams. And when you do chelation, try to get the lead out, all the stuff you do, you're getting out maybe 2 milligrams again. A small amount compared to what's in your blood. This is why chelation is not very useful. We'll talk about that in more detail this afternoon. Chelation of lead poisoned children or adults, especially when the poisoning is low in its levels, is not very efficacious because it doesn't pull out too much lead, 2 milligrams. It is useful if you have somebody who has life-threatening lead poisoning with encephalopathy. Now that's a different story because there it may make a difference. But in our children that we are going to identify that have levels of 10, 15, 20, we have to think about chelation. What does it achieve? The key is not chelation. The key is prevention. So let's talk about the clinical effects of being exposed to lead. What happens to us? The first slide is probably the most complicated slide in the whole seminar today. And I don't want you to worry about it because the answer is quite easy. Lead acts in every organ of the body because it works on enzymes and processes that are ubiquitous and involved in many functions of our cells. So it doesn't really matter what the organ is. If the function is affected, it will affect the actual organ. Whether it's in the brain or in the blood or the intestinal tract, reproductive tract, all of these are affected by these biochemical processes. They're inhibited by lead, or they're basically destroyed by lead. The process is damaged by lead. Lead can bind to sulfohydryl groups, can look like calcium and interfere with calcium processes. And you know how calcium is important for our body and sulfohydryl groups are important for our body, and therefore lead can affect these very well. I will show you, however, the effect of lead on the production of heme. Heme is another important chemical in our body that is involved in many different processes, the most important of which that we think about is blood, right? Hemoglobin. And lead does two things to two enzymes. The first one is the alpha-levulinic acid, D-aminolevulinic acid, dehydratase. It blocks that enzyme. The other one is ferrochelatase. What this leads to is inability to make heme, and that can result in anemia, of course. But it will also result in the accumulation of protoporphyrin. So before you make heme, you go from protoporphyrin plus iron gives you heme. Lead inhibits ferrochelatase, and therefore you are no longer able to go from protoporphyrin to heme. So now you have an excess of protoporphyrin. Why do I want to talk about that? Because that's another blood test that we can do. We can measure the levels of protoporphyrin in the child or the adult. We'll talk about how we can use that in our clinical setting. But that's why it increases, because ferrochelatase is inhibited. The inhibition of the D-aminolevulinic acid dehydratase will lead to an increase in the levels of D-aminolevulinic acid, which also can be measured. I will talk later on about the use of the protoporphyrin in our clinical setting. The syndrome of lead poisoning is worth looking at as a whole in this slide. I know this is a small slide. You'll have it in your handout. But I put it up there just to show you the broad spectrum of organs that are affected. I also want to show you how in adults, you may notice or you may see that the levels are a little bit higher than in children. It's because children are more vulnerable than adults. Children are still growing, are still developing, and have more processes that are ongoing and can be affected by the effects of lead. Also, children have more lead in their soft tissue compartment compared to adults. And that labile lead can affect the brain and other organs because these soft tissues can still move lead back and forth and cause organ damage. And therefore, you see the lead levels in children are a bit lower to cause the same toxicity that you see in adults. There are also some differences between adults and children. For example, adults, you see more neuropathy. You may see nephropathy compared to children, where you see the focus is the neurologic development. So keep this kind of dichotomy in your head as we dissect every single one of these organs together. The good news about lead toxicity is that we can measure also the blood lead levels and use that to assess the severity that we are looking at. So in children, for example, when we know that severe toxicity usually is between 70 microgram per deciliter and above, these are the levels that are the most concerning, and those are cases that I personally have never seen, because in the US these cases are very rare, but I'm sure these cases are seen in the world. In Nigeria, they were seen quite a bit in that outbreak where they had levels up to 400 microgram per deciliter in Nigeria. And they had about 400 plus children die from lead poisoning. Now these are situations where you have encephalopathy, and I hope our pediatrician will always look for these cases of a child coming in with seizures, a child that has some anemia and had some abdominal pain or constipation before that. They should think about lead. And they have to suspect this clinically, because the testing will not be immediately available and the management must start immediately. It's a big problem if it happens in a child, because it has a very bad prognosis. These children, even if they recover and survive, they will have 35%, 40%, 50% chance of long-term neurologic deficits and problems. So catching this is very difficult because the symptoms initially are very subtle. The patient, the child, may have some weird symptoms of headache, trouble sleeping, not eating very well, vomiting, abdominal pain, some gait problems. And the mother or the father may not be alarmed by this. They may think they have an infection or they are just dehydrated, but then they will present with delirium and hallucinations and coma, which has also associated with it the increase in the intracranial pressure, papilledema, and herniation, which can be fatal. This is an example from our textbook. This is one day after being hospitalized. It's a 3-year-old boy. He had vomiting, altered mental status, then seizures. He had blood lead level of 200 microgram per deciliter. This was one day after the hospitalization. And you can see the cerebral edema on the CT scan. His MRI that was done 22 days later shows the atrophy of his brain. This child will not recover. Even if he survives, he will have neurologic deficits. The next area of toxicity we were going to talk about is a little bit lower than 70. You do not have here a encephalopathy, but now you have some significant neurologic issues. Could be missed though. The child is hyperirritable, he's sometimes sleepy, lethargic, is not playing like they usually do, is called a difficult child. May have some gastrointestinal problems as well with vomiting, abdominal pain, or anorexia. So that's the other category. The third category, which is probably going to be the most common category we will see clinically in our hospitals, will be when the lead level is less than 50 microgram per deciliter. Even more subtle neurologic findings of problems with the thinking process, the cognition, problems with the behavior, fine motor coordination, issues with hearing, impaired growth, like a short stature when you watch these kids in your clinic and they start having developmental delay and their growth starts slowing down and falls off the curve. These are tough to catch, but these are your largest population. There is less than 50 microgram per deciliter. This is why it's important for you to look for these. And if you don't think of these, you will not find them. Most likely the parents will not complain about this to you. You have to ask about it. They will not tell you. You have to ask. You have to remember that this is important for your patient and you have to screen for it in your clinic. Every time you see them, regular visits, you have to, on an annual basis, you have to screen them and ask them these questions. If you see the anemia, then you are lucky because you can have a hint here. You have some clues. If you see, like I said, it's going to affect your heme synthesis, so you will see a hypochromic, usually microcytic anemia. Remember though, it's not 100%. They can have normocytic, they can have normochromic. Lead toxicity also causes hemolysis because lead affects the cell membrane and makes their cell membrane prone to destruction and hemolysis. So you can also have hemolytic anemia. The hemoglobin typically starts decreasing when you're in the 50-40 microgram per deciliter range. Some people say 25 microgram per deciliter, but these are your asymptomatic patients. These are your patients that have very subtle neurocognitive disorders that may be missed in the clinic. The biggest issue for children in lead is the cognitive development and the neurologic damage. This is what we are really eager to prevent from happening in our children, because we know that lead exposure in children will decrease the IQ, and that's an important thing. We know it's associated inversely and significantly with lower IQ, and that's an important battle to fight around the world. The one thing that's concerning, Dr. Khalidzi, this is some new research that led to the CDC changing, the US CDC changing some of the ways we consider lead hazards, is this slide. This is a study that showed that we have issues also with the IQ below 10 microgram per deciliter. That's the recent problem that led CDC to say there is no safe level of lead. There should not be any exposure to lead. We should all work on managing this to zero if we can. And now we use 5 microgram per deciliter, which is now called the level where you have 97.5% of the US population tested and enhanced. We don't call it anymore a level of concern. We refuse to say that. There's no level of concern. All levels are levels of concern. We just use a bell-shaped curve and we look at the percentile. And currently we're at 5 microgram per deciliter. It used to be 10 microgram per deciliter. But then this research has shown that you have a decrease in the IQ. And there's one more thing that's concerning. It showed that the IQ decline is more pronounced from 1 to 10 compared to 10 to 20 microgram per deciliter. We found that from 1 to 10, you lose 7.4 points in the IQ. From 10 to 20, you lose 4 points. So from 1 to 10 is no longer something that we would say is less significant than 10 to 20. We have evidence that says that it's maybe more significant. And therefore, we need to all work together on eliminating lead hazards in our children and families. This is important for our children because when they grow up and they go to school, it may affect their ability to achieve good results on standardized reading and math tests in the 3rd grade. We can have problems with attention, language, memory, cognitive flexibility, visual motor integration, etc. All of this has been shown in different types of studies. So we have to gear up pediatricians and obstetricians and primary care doctor to fight this problem and look for these subtle findings in our patients. Very subtle. Decreased learning and memory, decreased verbal ability, ADHD, attention deficit hyperactivity disorder, very commonly diagnosed. Do we think about lead when we see a child like that? Impaired speech, impaired hearing, lower IQ, irritable child, lethargic child, mild fatigue, myalgias, paresthesias, abdominal pains, etc., etc., to the high level where you start seeing the colics and the encephalopathy and more significant neurologic damage issues. So you see how difficult it is for us to tackle this problem? And our biggest weapon is history, screening history, maybe physical exam. Testing, management, medical management are going to fall behind. Prevention is the weapon here, not treatment. It's prevention. Let's move to adults now that we've talked about children. We see similar effects, but at higher levels here with the adults with the encephalopathy. You see a similar encephalopathy. But you also see some more prominent neuropathies. I'll show you a video about the neuropathy in a little bit. You also see nephropathy that can happen, and gout. The encephalopathy, I'm not going to repeat. It's similar to the one in children, of course at a higher level. But there's also the lead colic, which is quite famous. It's a severe abdominal cramps. They're very painful, that occur in episodes. They recur many times in one day or several days, and they also last minutes to hours. And they're very severe, and sometimes they get better by putting external pressure on it. So people will start bending into a fetal position, try to stop the pain. It usually occurs with severe lead levels greater than 60 microgram per deciliter. With lower levels, you may see some cramps, but not the typical colic. And it's treated with chelation or calcium gluconate. I don't have any personal experience managing these cases. I've never seen a real lead colic, though my Indian patient that had the levels that I told you about, he was having abdominal pain, but he didn't have the severe colics that are described here for you to look at. The neuropathy is also important in these adults. Typically, you'll see a motor neuropathy. When you see somebody with a sudden onset, wrist drop or foot drop, think about chronic severe lead exposure. Ask them about them having any metallic taste in their mouth, any abdominal pain, constipation, and your nephropathy. Kidney will also be damaged, and that will lead to gout because they're unable to clear uric acid. So serum uric acid will go up and you'll have gout attacks. And don't forget about your anemia, myalgias, muscle weakness, and arthralgias. Other chronic effects in adults are fatigue, being moody. I've seen several cases in my clinic of adults that have levels in the 50, 45, 55. These are people that work with lead. They are welders, they work with glass. They smoke when they work. They don't wash their hands before they eat. They eat at their workplace. And they would come in to me telling me, I'm tired, I have a headache, I'm very moody, my wife thinks I'm changing my personality. I have decreased interest in sexual relations, so I have decrease in libido. We are not having kids, we're unable to have children, we have infertility problems. Also, we get concerned because hypertension is clearly associated with lead exposure. And you don't have to have very high lead levels. You can have low lead levels in the 10, 15, 20 microgram per deciliter. Some research even shows it below 10 microgram per deciliter associated with hypertension and nephropathy. We are even looking at cardiovascular disease as much as it relates to hypertension. Whether you see strokes or coronary artery disease, less strong of a link. Dementia also, less strong of a link. And finally, cancer. Cancer is another area of interest right now and research. And I'll talk about cancer in a little bit. But in these adults, preventing lead exposure can help in preventing hypertension or decreasing the renal effects that can occur from these elevated lead levels. You can also see on exam Burton's line. I've never seen this personally, but you see lead sulfite deposit in the gum and causes this grayish, bluish line on the gum. So look into that. Now remember, this is not very common, but keep that in mind. I know in Georgia, it's very important for us. Children is very important for us, right? Baucheba, right? And lead causes problems in male and women to have babies. Whether it's problems with the sperm count, sperm quality, or longer conception times for women, even at low levels. And that's an important thing for us to also screen for. And like I mentioned to you earlier about that woman, she had these miscarriages, which could have been explained by her lead toxicity. Because it can cause miscarriages, it can also cause stillbirth. It can also cause issues even at low levels. The Mexico study that was published recently showed effects even below 10 microgram per deciliter in pregnancy outcomes. So now in California, this is an interesting topic in California. They are requiring blood lead levels in pregnant women. That's a problem. Because what do you do if you test and you get a level that's elevated? So what do? You treat them with what? With the chelators, right? The chelators also chelate zinc, manganese. That has a problem too for the development of the baby. So it's tricky. We've had one patient in our clinic that wanted to get pregnant, and she had a level that was elevated in the 40s. Very challenging cases to manage clinically if this happens. But certainly lead and pregnancy are a problem, and we have to screen for it potentially and treat it. And these babies, when they are born, if they're exposed to lead in utero, they will have a low birth weight, premature birth, and they can even have learning disabilities, even if they have no exposure after birth. Just what they got to the uterus and the placenta can affect them. Good news is we don't have any clear evidence for congenital abnormalities. So these babies, when they are born, we don't have evidence for congenital abnormalities, like for example missing limb or something like that, like what you see with Zika. But you can see the developmental problems that can occur. Cancer is an area of active research. I know in Emory there's a collaboration for a registry looking at cancer, specifically lung cancer. But for now, it is classified as a probable human carcinogen. So probable. Based on animal studies, we don't have good human studies. And as I said earlier, the prognosis depends on the severity. In your severe cases with encephalopathy, the prognosis is not very good. Mortality has been reduced over the years, but you can still have significant neurologic deficits if you suffer from encephalopathy. If you have a neuropathy and you stop the exposure, you may have an improvement in the neuropathy, but it will take a couple of years for it to get significantly better to normal after you stop the exposure. So that's, in summary, the entire spectrum of clinical effects of lead, inorganic lead. I want to show you one case of organic lead that happened recently in Iraq. Here, the organic lead is absorbed through the skin, orally, by inhalation. This 13-year-old boy accidentally ingested a mouthful of a fuel stabilizer containing 90% of tetraethyl lead. He developed tremors, weakness, hallucinations, myoclonus, hyperreflexia. He required to be intubated and ventilated for 2 days. And currently he has persistent hallucinations, weakness, dysphagia, urinary and fecal incontinence. Certainly severe outcomes. His peak blood lead level was 62 microgram per deciliter. Remember, organic lead in the body gets converted to inorganic lead. So he ended up having elevated inorganic leads. But here you cannot rely on the toxicity is not from the inorganic lead. It's from the organic lead. And doesn't correlate with the levels like we saw earlier. So now we are done with the actual clinical effects. The next topic is the assessment, which is the lab testing, and then the management. I will propose to continue until you stop me at 12. We can always stop. This is kind of a continuous set of slides. If that's okay with everybody, or you're too tired? Okay, we'll continue another 20 minutes. So again, the onus is on you to perform your history and exam in your clinic. You have to catch these cases by taking a good history of occupational history of the parents or the patient himself if you're seeing an adult. What do they work? Does their work involve lead exposure? What about their home? Is this an old home or a new home? Is this a home that's been renovated recently? What about the paint in the home? Is it falling apart? Do you see chips? Is it flaking? Are there areas in your house where you see flakes of paint? Levan is going to talk about some of the strategies to mitigate or abate the lead risk from a home later on. What are the hobbies of the parents or the children? Do they work with lead in their hobby? Do they use traditional remedies or herbs that are imported from India or from the Middle East? Does the child show pica behavior? Does the child eat foreign substances or bodies? Do they have a behavior to do that? Do we smoke at home around the child? Has the child ingested a foreign body? A lead bullet, a lead sinker weight? Does the patient have a retained bullet? Right now I have a patient that we're following in our clinic that was shot and has lead fragments in his body close to his spine, and we are monitoring his lead levels. That can also cause increase in lead levels in the body, especially if the bullets are inside of a joint where the synovial fluid is acidic and can leach the lead out, especially if you have a large number of fragments, especially if you have a long bone fracture, especially if you are in the peritoneum where you also have the peritoneal fluid. All of these increase your risk of lead toxicity or elevated lead levels. Toys. I remember in Georgia a few years ago we had the ministry found some toys, right? They had lead in them. That's a hazard for children that put these toys in their mouth frequently. So it all starts in the history. And you can look at this history later on. There's no need for me to go through it one by one, but this is how you ask these questions to your patient's parents or your child or your adult, and you will have this with you, and you can look at that and print it and look at it at your leisure. I just copied and pasted this questionnaire from the CDC. Now the blood lead level is important. Dr. Kamkhalidze talked about the importance of doing the right test. The gold standard is the ICP-MS, which we are going to do in our study with our colleagues from the Italian National Institute of Health. This is the gold standard. This test result, the blood lead level, is important. Also though, more important is collecting the blood sample properly, because you have to use a lead-free tube, and you have to also clean the area very well and make sure there's no environmental contamination of the needle where you are testing, where you're drawing the sample. Very important. We, in our first study, used a lead care analyzer, which is a point of care test. It's usually meant for capillary samples, but we used a venous sample. And this is what was recalled by the United States Food and Drug Administration as possibly producing lower results than what you get, than the reality. So the capillary testing is good for screening if you have a low-risk population and you don't want to stick the baby's venous system. You can do a capillary stick, but also you have to clean and you have to make sure everything is done properly, and you can get a result. If it's elevated, you have to follow up with the blood lead level using the ICP-MS. So in the future, 2 or 3 years from now, when we understand better the lead issue in Georgia, yes, we can maybe start doing capillary testing in our clinics. But for now, we need to really get the gold standard. We need to get a good assessment of the situation. Now, remember I told you about ferrochelatase, that enzyme, ferrochelatase, and we talked about the zinc protoporphyrin test. This is a test that measures the protoporphyrin that accumulated because you inhibited the enzyme that makes heme. The important thing about this level, that it actually lags behind. So you get lead poison today, your blood lead level goes up tomorrow, your ZPP level, the zinc protoporphyrin level, goes up several weeks later. So it will help us differentiate acute versus chronic exposure to lead. We may use it in some situations. The one problem with it that I actually saw in my clinic a few months ago, I had a patient come to me who had already seen his doctor and had an elevated zinc protoporphyrin level. But his lead level was 1 microgram per deciliter, and he was concerned. So I told him that your zinc protoporphyrin level can go up from other diseases, not just lead. Just having anemia of chronic disease can cause your zinc protoporphyrin level to go up. And this person was anemic from iron deficiency. So that was his problem. But if properly used, you can maybe understand the acuteness of the exposure to the lead. Because if you have an elevated blood lead level and a normal zinc protoporphyrin level, then the exposure was quite recent because the zinc protoporphyrin has not increased yet. If they are both elevated, then it's a subacute or chronic exposure. So this is something that we can think about, and us, when we work together on the study, we can see when and where we need to use this situation. I see many patients in my clinic that are falsely tested. Unfortunately, in the United States, we have many clinics that make a lot of money from testing for lead improperly. They tell the patient that, we can chelate the lead out of you, or we can chelate things out of you. It's good for you to remove everything. And they want to give them the chelating agents. And they'll do these tests for them that are not reliable and not indicated. So please, we will not be checking urine lead levels. We will not giving chelation and checking lead afterwards. Those are all practices that should not be used in Georgia, and we should not encourage them. I mentioned the X-ray fluorescence a little bit. This is done in about 30 places in the US, where you actually irradiate the leg for 30-60 minutes with photons, and then you detect emissions from the bone, and will give you an idea about how much lead is inside the bone. That's a good way to give you an idea about the chronic burden of how much is lead inside the body. But we don't have enough information about how to use that information, those results. We don't have good studies that tell us this result means this for the health effects. On a CBC test, you can see basophilic stipplings. The basophilic stipplings in the erythrocyte is because you inhibited the ribonuclease enzyme. Lead inhibits ribonuclease, and you are left with these RNA fragments that you see. It's good to see that these levels will appear 3 to 4 days later after an acute exposure. But remember, they can also appear with benzene exposure, with thalassemia, arsenic, and cancer. So not specific. Lead lines in children in 1 to 3 years of age. You can see the inhibition of proper growth of the bone, and you see calcium deposition because of the lead. This is not lead you're seeing, it's calcium that is depositing in that way because of the lead. This is typically seen if you are younger than 6 years old, but also can be seen in neonates, and will go away afterwards. And you can see it with a level of 50 microgram deciliter of blood lead level. And it's nice because you can do it in your clinic, in your hospital. So if you have a patient comes in with a seizure, a 3-year-old comes in with a seizure, encephalopathy, and you are wondering, could this be a lead poisoning? Maybe you can do an X-ray and see if you find it. If you find the lead lines, that will reinforce your diagnosis, which is clinical at this time, right? And you have to treat. So this will be a useful way to do it. Because these patients can get very sick, they need an intensive care unit, they need to be treated for herniation, and they require IV chelation. But fortunately for us, our most common cases will not be that severe. They'll have lead levels less than 45 microgram per deciliter, and will have these subtle clinical manifestations. In these cases, the only thing we can do is going to be prevention, primarily prevention. Although there are a few medical management techniques that we can talk about. For example, if they have lead in their stomach because they're eating paint chips, or they have a lead foreign body, we have to remove it with whole bowel irrigation. Remember, charcoal will not bind lead. We have to do whole bowel irrigation. Sometimes you have to do endoscopy if there's a foreign body, like a bullet. You have to remove it because this bullet can make you toxic. Okay? And that can be quick. So you have to act. The chelation therapy, we only have a few ways. We have British anti-Lewisite, we have calcium disodium EDTA, we have Succimer and DMPS. I will talk about each one of these today. But remember that all of these chelators, none of these chelators has ever been shown to make a difference on the IQ and the cognitive function. So the chelation is really, IV chelation with calcium disodium EDTA can help in your encephalopathy patient, reduce the mortality, help with the hematologic effects. But the cognitive deficits, if they already occurred, chelation will not reverse them. What reverses them is good nutrition and removing them from the exposure and preventing further exposure. So again, decontamination is important. If you see it on X-ray, for example, paint chips like this here should be removed with whole bowel irrigation. And if it's a bigger foreign body, you can also go after it by endoscopy. Okay? Once you diagnose somebody with an elevated blood lead level, there are also guidelines about when to repeat the test and confirm it. So there are some guidelines. I don't want to bore you with these slides here. These will be available for you. And there are also guidelines. This is CDC guidelines. I'm sure you know the WHO has guidelines as well. We will make guidelines in Georgia. We will make guidelines that fit best the Georgian needs, using the best evidence from our international partners for the safety of our communities. And we will decide how we are going to follow up on our patients. This is going to be a public health battle to control the problem as a next step, as Basil was saying. First step is to characterize it, then to raise awareness about it, communicate it, and then act on it. And this is already something that is going to start hopefully with our first step in September. This will involve many partners. We need to think about the home environment. What do we do about it? Do we have the appropriate technical expertise to clean a house from lead contamination? We're ready to take care of the gasoline problem. What about the food? What about testing of water? We tested the water twice in that home and it was perfect. It was very clean. Although this family was drinking water from a pipe in the garden. When I visited their home, I thought it's gotta be the water. I took a picture of the pipe. It was an old pipe. And I said, for sure, it is the water. But I was surprised. It was actually not the water. The water was tested twice, once in Georgia and once in the US lab, and it was below any level of concern by the EPA. Toys and regulations around toys and importing products and traditional remedies. With all of these public health measures, we will succeed. The US success story is shown here as a result of several public health measures. Whether they banned lead in paint through the Lead-Based Paint Poisoning Prevention Act of 1971, lead in plumbing banned in 1986, ban on lead in solder in food cans in 1995, banning lead from gasoline. All of these led us to decrease our blood lead levels in the US from 16 microgram per deciliter in the 70s to today 2.5 microgram per deciliter as a national mean. So this is not impossible, but we need your help. The NCDC and the Ministry of Health are serious about this. They have the appropriate partners, they have the appropriate resources, but you are the soldiers in the clinics who are going to identify and raise the awareness and treat. And then we are going to talk about an important step in our battle with lead, which is basically what do you do with the existing lead contamination? So what do you do with the lead in the house, in the soil? So it's called the lead abatement. And then we'll finish up with a case that we are going to go through. This is really going to be the interactive session. This will be also the session where it will be a question and answer. The case is only going to just stimulate the discussion. So once you have a patient that already has elevated lead levels in their blood, and you have applied all your prevention strategies, education of the parents, etc., what can you do with medications. Are there medications that can help you? This is the next session. The first medication was one of the first medications created for this, called dimer-caprol. You may have heard of this medication. It was made after World War I, and it's called British Anti-Lewisite, BAL. That's dimer-caprol. Remember I told you that lead in our body binds sulfur groups. This chelating medication has 2 sulfur groups. This is why it binds lead. BAL is miscible in peanut oil. So it's when you take it, it's miscible in peanut oil. So if you have peanut allergy, you cannot take it. It is currently still used when you have a severe case of lead poisoning with encephalopathy. So you use it not alone, you use it with calcium disodium EDTA. So you give the first dose of BAL, and then 4 hours later you give tetacine. You do that because tetacine can increase lead in the brain. So you get BAL first to prevent redistribution to the brain. And then you start tetacine, continuous infusion, and every 4 hours you give BAL, just to make sure the lead doesn't go to the brain. This is how you use this treatment for severe lead poisoning with encephalopathy, severe abdominal colics. Also you can use it for that, severe lead colics. Now BAL has some adverse effects. It can cause a lot of nausea, vomiting. It is also a problem if you have a peanut allergy. It can also cause fever, like fever and chills. And it can cause sterile abscesses because it's a deep muscular injection of this peanut oil-based therapy. The second drug is tetacine. In the past, tetacine was different. It was disodium EDTA. And when that was used, it caused life-threatening and lethal hypocalcemia. So they stopped using disodium EDTA and they switched it to calcium disodium EDTA. So they gave calcium with it to avoid the life-threatening hypocalcemia that occurred. This drug will remove lead through the kidney. It will increase the urinary excretion of lead and participated in the decrease in the mortality from lead encephalopathy from 30% to 5%. Certainly, with the use of tetacine, we have also seen improvement in ICU care. So it's not only the tetacine that decreased the mortality from 30 to 5%, but certainly helped in these severe cases of lead encephalopathy, along with British Anti-Lewisite or BAL. It also effectively reverses the hematological effects of lead, but does not improve the cognitive function. Unfortunately, like I told you before, no medication can improve the cognitive function. The best way to treat lead poisoning is to prevent its occurrence and provide good nutrition with iron and calcium supplementation. The dosing of ketacine in lead poisoning depends on if you are treating encephalopathy or nephrotoxicity or just an acute symptomatic lead poisoning. The key here is to treat and then you stop for 2 to 4 days to rest the body, and then you resume. And the treatment of this is not always available. Tetacine is not a medication that is commonly available, nor is British Anti-Lewisite. In the past, we used to do this calcium disodium EDTA mobilization test, which is now no longer recommended and should not be performed. Currently, some clinics use it because they want to try to show the patient that they have lead inside their body, but this is not something that is recommended anymore and can have bad side effects. The major issue with ketacin is kidney. Acute kidney injury as an adverse effect and renal failure. And like I said to you earlier, the sodium EDTA product is no longer used because it caused life-threatening and lethal hypocalcemia. The third medication that you can use is the newest medication on the block compared to BAL and ketacin. It's Suxamer, or DMSA. This is a drug that was initially manufactured and discovered in China. It's an oral medication. And as you see, it has a lot of sulfur groups. You're not surprised to see the sulfur groups because those will bind your lead. Its cousin is shown on the right, is DMPS. This drug is dimercaptopropaenosulfonic acid, is also very similar to Suxamer. Both of them are very similar to BAL. They're derivatives of BAL. This one is also used orally or parenterally. The US doesn't manufacture this product. It is available through some special pharmacies. This drug, DMPS, is available in Russia and also Germany. So I would imagine this could be an option for Georgia. Suxamer is also available in Europe. I have more experience. Personally, I've never used DMPS. I've used Suxamer. Suxamer is difficult to ingest because it has a bad smell and taste. However, you can potentially add some juice with it so to make it more palatable. And it has a low bioavailability and is highly protein bound to albumin. And the half-life in pediatrics is longer than adults. It also causes enterohepatic circulation, but does not cause CNS redistribution of lead, like BAL. We had a lot of hope on Suxamer because it was an oral medication. It was relatively safe and easy to use. The problem is the prospective studies that looked at its effect on cognitive deficits have failed to show a benefit. This major study that was undertaken failed to show in 780 children an improvement in the cognitive function. It lowered the lead level, and eventually the lead level increased again by itself, a rebound. And when they tested the cognitive function of these children, they saw some minor improvements, but not statistically significant. So this is why I tell you that chelation has never been shown to improve cognitive function. This treatment of lead-exposed children trial, the TLC trial, was a good trial. It was a randomized, multi-center, double-blind, placebo-controlled, a very good trial. And they looked at lead levels, which were those lead levels that we were talking about, 20 to 50, right? These are the lead levels that we want to try to do something about, because these are the most common piece of the pie of the poisoning that we are going to tackle. And they chelated children aged 1 to 3 years old. Perfect, right? Lead levels of 20 to 44 microgram per deciliter. And they performed neuropsych testing at age 7. They found that the lead levels decreased compared to placebo. However, the lead level eventually, after they finished the course of therapy, eventually increased again and came closer to what they were before the treatment. Well, compared to placebo. So, as if the benefit kind of waned after some time. And when they looked at the actual neuropsychiatric testings that they were done, those tests for cognition, they found that there's a failure of chelation therapy to alter cognitive and behavioral outcomes in preschool children with blood lead levels in the range of 20 to 44 microgram per deciliter. That's why I just told you that chelation is not the solution. The solution is prevention and education. And we all see a rebound in the lead levels after we stop Succimer to 20% to 40% lower than the pre-treatment value, but they will rebound a little bit. So they don't stay very low for forever. They go back a little bit. They're lower than it was before treatment, but they're getting close. That said, though, currently Succimer, or DMSA, is the drug that we use the most commonly in the United States. It has some mild side effects that are tolerable, with GI effects, some mild increase in the liver function tests. It can also chelate zinc or calcium. So when you treat, you should probably supplement calcium and zinc, especially if you're treating a pregnant woman. But in general, it's a very safe, relatively safe medication. And you give the treatment at 3 times a day for 5 days, then twice a day for 14 days. So the course is about 19 days. In Nigeria, where we talked about all these cases, they've used Succimer because they did not have EDTA. And they were treating people at home. They didn't have enough hospitals to treat everybody. And in that outbreak, they used Succimer, and yes, they were able to decrease the lead levels. At the end at the end of the course, the percentage of the lead level was 74% what it was before the treatment. And when they actually looked at only patients that were treated in the hospital, where they knew for sure they were taking the medicine because they were giving it to them, so the compliance was presumed to be high, they were able to get to 47% of the level before treatment. So yes, it can lower the blood lead levels. It may cause a rebound later on, but unfortunately the research has not shown that it makes a difference in the child's IQ. Unfortunately. And now, we had experience in our center in Atlanta in 3 children where we actually treated them with DMSA and calcium disodium EDTA instead of BAL. So we used DMSA or Succimer instead of BAL to prevent CNS distribution. So that's also starting to be used in some centers because BAL we don't have commonly, and it also has some adverse effects. So now the ideal treatment would be, if you have a severe case here with encephalopathy, you could just do EDTA and Succimer. Last but not least is DMPS, which is another similar drug to DMSA. I don't have much experience in it, except that it can be used also IV and has a similar profile as Succimer, but it has a couple of case reports of Stevens-Johnson syndrome that resolved when you stop the therapy. They can also cause bycatch, where they can capture other metals as well as the lead. So in summary, prevention is more important than chelation.